Okay, hello everyone. Our topic for today is about spinal cord segments, positional changes of cord, and cauda equina. So, a good tip about the exam is that you always have to start with the very basics of your questions. So, if you get this question, it would be very good if you start about the definition of spinal cord. Start with the most superficial knowledge that you have, and then you start go deeper. So, what is the spinal cord? The spinal cord is a cylindrical structure that runs through the center of your spine from the brainstem till the lower back. It is a very delicate structure and contains nerve bundles and cells that carry messages from your brain to the rest of your body. Next, what is the purpose of the spinal cord? Another one very basic question. So, the main purpose of spinal cord is to carry nerve signals throughout the body. These nerve messages have three crucial functions. First, control body movements and function. Signals from your brain goes to the other parts and control your body movements. It controls the muscles and helps you assist you in movement. But they are also carrying direct autonomic functions which are involuntary. For example, your breathing rate, your heartbeat, also some also bowel and bladder function. The next one is that it reports senses to your brain. And the last one that we're going to talk about later more extensively, uh, spinal cord is responsible of managing your reflexes. And now, what are the main parts of the spinal cord? And now you start getting deeper into your question. So you have three main parts. You have the cervical, the thoracic, and the lumbar. Cervical part is on the neck, thoracic part is on the chest, and lumbar part is on the lower back. Okay, so the cervical part, it's responsible for the neck and the upper extremities. And as you can see, its specific part is controlling a different part of your body. For example, C1 and C2 are responsible for head and neck muscles, C3, C5 for diaphragm, C6, T1 upper extremity. Thoracic part is from T1 to T12 and is mainly responsible for chest and abdomen. The lumbar part is about the lower back and the legs. And then you have the sacral part, also responsible for the sacral plexus, and lumbar for the lumbar plexus. For the sacral part is from S1 to S5 and is controlling the pelvic region and the lower extremities. And the last one is the coccygeal part. This is the smallest region of the spinal cord, and it is located at the bottom of the spinal cord, and it is associated with the tailbone region. You also have a nerve bundle at the base of your spinal cord called cauda equina. This word, these two words are from the Latin, and it actually means horsetail. Because early anatomists thought the nerve collection looked like a horsetail. If you see it dissected, this structure is very unique. So pay attention in the dissection to keep an eye on the cauda equina and how it looks like. The cauda equina includes nerves that provide sensation to your lower body. Each spinal cord segment contains both sensory and motor neurons that allow communication between brain and the rest of the body. So, my last point for the segments of the spinal cord is that you have to remember that its spinal cord segment is identified by a letter and a number. For example, C1 is C1 for the first cervical segment, T6 for the sixth thoracic segment. The spinal cord segment also have reflex arcs that allow quick and automatic responses to sensory stimuli, and we're going to talk about it later. And now I give the floor to Abid.
Hello, guys. My name is Abid, and I will be covering vertebromedullar topography with you and specifically Shapol's rule, as well as things called the curves of the spine. All right. Um, just kind of going off what Jonas said earlier, I just want to reiterate that this particular topic isn't very high yield, which means that these are topics that you need to understand. However, you don't need to know them perfectly. With examiners such as Professor Nemtsova or Professor Shabat, you can expect to be asked about something else because this particular topic tends to also deal with the peripheral nervous system. You should be very thorough in the basics as well. Um, this is frequently because they just want to confirm whether you do know things or you just happen to know this one thing and you're going to pass because of it. With that, we shall just begin. Shipol's rule. Now, Shipol's rule actually talks about the levels of the vertebrae and how they are related to the actual origin of the spinal nerves themselves. So we can see that here we have the cranial spinal nerves, and then we have the thoracic, and then the lumbar, and then the sacral. But you can kind of see if you look at the colors and how they correspond to the regions of the vertebral column where they exist. You can see that they originate at a different place and then they exit at another. Now, this is what we call a discrepancy in the exit and the origin. So that's the first important point that you need to remember. The lower you go in the spinal cord, the more of a discrepancy you can expect to see with the exit of the spinal nerve and the level at which it originates. Now, you can expect to be asked why this happens, and very simply, it's because it grew that way. Um, the spinal cord actually ends like finishes growth at a certain point, but the rest of the body continues to grow on. And so what ends up happening is that to make up for it, the nerves that need to go to the lower limb, so the nerves of the lumbosacral plexus as well as the sacrococcygeal plexus, etc., they just tend to lower themselves further and exit at a lower part so as to reach their intended destination. So that's the discrepancy. Now, another question is there are 8 spinal nerves, but only 7 cervical vertebrae. Why does this happen? Um, the simplest way to explain it is because if you think about it from an embryological point of view, there are actually 8 cervical vertebrae. This is because the bottom of the skull, at the base of the skull here, forms from the same sclerotome as the first cervical vertebrae. So it's technically the first cervical vertebrae. And then this is C2, and this is C3, and so on and so forth. So there are actually 8 cervical vertebrae, and therefore, suddenly all these 8 spinal nerves correspond perfectly. Of course, this was not named this way because, simply put, it doesn't look good. You can separate the base of the skull and you can remove the entirety of the vertebral column, and you can see that it has a set number of parts, and the base of the skull isn't one of them. So it was more of a matter of it looks good on paper, therefore, there are 7 cervical vertebrae. So you can remember it as just for the cervical vertebrae, the C1 exits above the C1 cervical vertebrae, then the C2 exits above C2, and so on and so forth. And then C8 comes below C7. But from that point onwards, it is T1 below T1, T2 below T2, so on and so forth, right? Uh, that's another important thing that you need to know about this particular topic. With that being said, that's everything that's important about this. You can take a chance to go through this. However, it is not as important as you might think. Um, then the damage of the vertebral column, right? What happens if you damage a specific section of your vertebral column or your spinal cord at a specific point? Simply put, nothing below that point will function properly. Because if you think about it, the spinal cord is basically a highway of information. If you put a block at one point, everything before that block wouldn't be able to pass anymore. So, if you have damage that occurs at the cervical spinal area, then anything below that, which was technically on the other side of the block, wouldn't be able to pass information up. So, damage here, everything below that doesn't work. What does it translate into clinically, right? If you have a damage in your neck, say because like it's a cervical spinal area, damage in the neck means anything below that wouldn't work, which we call tetraplegia or quadriplegia. Then if you have a damage in the thoracic area, uh, you can expect the you know part of the lower part of the body to not function properly, therefore paraplegia, right? And then finally, we have the lumbosacral regions that get damaged, and then it's just the lower limbs that would be affected. Um, it's a thing that you need to know, especially in the clinical parts of the semester. I believe there are specific regions that correspond to specific vertebral levels, and they're very good to know. C4 corresponds to a particular thing, if I'm not mistaken. Then you have C7, which is the most, felt on your back. C7 cervical vertebrae can be felt very easily. Then you have T4, which is at the level of your areolae and nipples. And then you have L4, which is roughly at the level of your belly button. So yeah, these are particular points where it is, fairly important to know where they are and how they look. Nice. With that, we move on to curves of the spine. Now, curves of the spine is fairly straightforward. It is the physiological curves. So when it comes to that, you just need to answer what, where, and why they exist. What are they? They are physiological curves, and they do not represent any pathologies unless they are excessively curved, right? So when you view it from the side, as you can see in this picture, you have convex curves and concave curves, right? Uh, con Convex curves going up here and convex going here. You can see, right? Now, where are they? There are about three or four curves depending on how you visualize them: the cervical, the thoracic, and the lumbar. It is always safer to go with four curves instead of three. This is because the some textbooks do not count the lumbosacral curve as one. However, it is still a physiological curve that is expected in the spine. Therefore, you should say it. Why? Why do the curves exist? Very simply, it's good for shock absorption. You need to dissipate the force that comes from your lower limbs as it travels upwards. And if you have a ramrod straight spine, it isn't going to function as well as a curved one would, because you wouldn't be able to effectively dissipate force. The joints would suffer, and you would have incredible amounts of erosion at the joints, and then it would lead to, inability to bend over and things like that. Why are the curves important? Their clinical significances. Excessive curvature can alter the balance of the body and cause bad posture. The balance of the body becomes incredibly important in the second example, which I mentioned, which is scoliosis. But it's important to mention that here you can have a curve that appears to be normal, like it's in the normal place that it should be, but it is excessive, right? So it leads to things like hunchback, which is a problem that is commonly seen in people who tend to round their shoulders. Scoliosis is the same curving of the spine, however, instead of it being anteroposteriorly, it is more side to side. And it again affects the balance of the body. And once it is corrected, usually through extensive surgery, the people who undergo the surgery need to relearn how to walk sometimes. So it is, often kind of painful to go through. Let's take a look at these curves and kind of go through them. So you have the lordosis and the kyphosis over here. You can see the lordosis, which I mentioned, was the concave curves, right? Then you have the convex curves, and then another concave lumbar lordosis. If you think about it, I can show you the thing on this particular model. If you have excessive curving over here, you can expect this to kind of bend forward, and then you have, instead of a cervical lordosis, you will end up having cervical kyphosis, which is convex, and then you have a hunchback, right? Um, Opposite, if you have here in the lumbar position, if you tend to bend to or overcompensate, you would have an excessive curvature like this, and then it would just kind of bend more inwards, become more concave, and you would have kind of like a pot belly kind of appearance in front, and your posterior, your buttocks, will tend to pop out more. So that's excessive lumbar lordosis, right? And then we can take a look at the sacrum and coccyx here, which is another kyphosis, which I said was the fourth curve, even though some textbooks do not mention it. With that, I will just end here and pass on the baton to Jonas.
All right, so Abid was perfectly explaining you the most complicated topic of our presentation. And now I'm gonna talk a little bit about um, the spinal cord segments and more deeper, get more deeper information. So one question that they like to ask in the exam is why the proportion of gray and white matter is not the same in all sections. So the answer to that is very simple because the amount of gray matter in spinal cord segment varies depending on the function of that region. So it means that the higher amount of gray matter allows more complex processing of this information. And an example to that is for in the cervical segments, for example, they are located closer to the brain and they have a higher proportion of gray matter comparing to the white one. This is because the cervical segments are involved in the processing of sensory and motor information that is related to and from the upper limbs and head. In contrast, for example, the lumbar segments of the spinal cord have a higher proportion of white matter compared to the gray one. And this is because the lumbar segments are primarily involved in the transmission of sensory and motor information to and from the lower limbs and only the lower limbs. Um, so the lower amount of gray matter in the lumbar segment reflects the simpler processing requirements of the information. And now we have to say some words about the reflex arts. As you guys know, we have two types. We have the monosynaptic and the polysynaptic. Monosynaptic reflexes play out with only two neurons participating in the reflex arts. One is sensory and the other one is motor. The first order neuron is always sensory. It is in the spinal ganglion. And the second one is motor, and it is in the anterior horn of the spinal cord. So to understand how this works, the sensory neuron gather impulses from the muscles and send the information to the motor neuron, which innervates the same muscle. The motor neuron then causes contraction of this innervated muscle. Um, it would be easier for you to understand with an example. Monosynaptic reflex is the stretch reflex. For example, when we hit the knee with a hammer, this is actually the initial stimulus, and then the muscle spindle senses this stretch, and then sensory neurons conduct action potential to the spinal cord, and then impulses are given to alpha neurons, and these alpha neurons leads to contraction of the knee. So as you can see here, we give the stimulus with the hammer, it travels, and it meets the motor neuron into the spinal cord, and the motor neuron initiating the extension of the leg. And on the other hand, we have the polysynaptic reflexes. They have multiple neurons that they are participating. Uh, Again, we have one sensory and one motor neuron, but what makes the difference is that we can have one or more interneurons. Um, and they are responsible for better for communication between sensory and motor neuron. They are, of course, more complex than monosynaptic reflexes because they involve muscle groups and not just a single muscle. A very good example of that is the withdrawal reflex. As you know, withdrawal reflex is happening when, for example, you are touching um, flame, or if you're touching the tip of a needle, and you directly take off your hand from this site of pain. And the last subpart of our presentation today is cauda equina. From what you can see in this picture is mostly the anatomy of the conus medullaris and the cauda equina. So the conus medullaris is the cone-shaped terminal portion of the spinal cord here. The tip of the conus medullaris is found between L1 and L2 vertebrae, and the conus medullaris is tied to the coccyx by a fibrous cord called filum terminale, which the function of filum terminale is basically stabilization of the distal end of the spinal cord. And here you can see how it will look like in the dissection room. This is the conus medullaris, and here is the filum terminale, and with number 3 you can see the cauda equina. So, structure. The cauda equina consists of the spinal nerve roots L2 to L5 and the coccygeal nerve. It lies within the distal third of the vertebral canal and extend into the sacral canal. It is very important to know that it occupies the lumbar cistern. And why is that important? Because lumbar cistern is an enlargement of the subarachnoid space containing cerebrospinal fluid. We'll speak in a little bit more extended about why this is very important to the clinical practice. And another one is function. You have to speak about the function of the cauda equina. So function, the nerves that compose the cauda equina, they have motor innervation of hips, knees, ankles, feet, the sphincters of the anal region, and also they are responsible for sensory innervation of the perineum and parasympathetic innervation of the bladder. And now we'll speak a little bit about the clinical importance of cauda equina. It is more. This knowledge is mostly about the next years, but it is very very interesting and it's easy to remember, and it's something that, of course, make a good impression to your examiners. So I'm pretty sure that you've heard about lumbar puncture. Lumbar puncture is a medical procedure that involves inserting a needle into the subarachnoid space of the spinal canal in the lumbar region. And the goal is to obtain a sample of cerebrospinal fluid for diagnostic or therapeutic purposes. For an anatomical perspective, the procedure is performed in the intervertebral space between L3, L4, or L4, L5 vertebrae. The site is ideal over there because it's the place where the spinal cord terminates into a bundle of the nerve roots, and this is the cauda equina. So the needle is inserted below the level of the spinal cord, and it gives us the advantage of avoiding the risk to damage the spinal cord. As you can see here in the picture, the needle is inserting over here, and it's difficult to hit the nerves than, for example, between L1 and L2, that you have the whole spinal cord. All right. And the last part that I want to mention is the cauda equina syndrome. And what is significant for cauda equina syndrome is that it's an emergency. It's a very rare disorder affecting the bundle of nerve roots at the lower end of the spinal cord. And So cauda equina syndrome occurs when nerve roots in the lumbar spine are compressed and thus disrupting sensation and movement. As you can see in this picture, there is a massive compression of the cauda equina over here. This, what you can see here, is a massive disc herniation. So it goes inside the spinal cord area and is compressing the cauda equina. Um, Nerve roots that control the function of bladder and bowel are especially vulnerable to damage. It can lead to permanent paralysis, impaired bladder and bowel control, and loss of sexual sensation. And with this, we are finishing our presentation regarding segments of spinal cord, cauda equina, and support rule. I hope you found it interesting and helpful for your final examination. So, thank you very much for your attention.